Prior to beginning the activity, please be sure to review the faculty information and disclosure statements, as well as the learning objectives. After listening to the activity, complete the post-test by clicking the Earn Credit link in the episode description. Downloadable slides and resources are also available. The following presentation is copyrighted by Medscape. No use, broadcast, or recording of this presentation or any part thereof is permitted without the written authorization of Medscape.
This activity includes discussion of therapeutic products that have not been approved by the U.S. Food and Drug Administration, off-label uses of approved products, or data that were presented in abstract form. These data should be considered preliminary until published in a peer-reviewed journal. Readers should verify all information and data before treating patients or employing any therapies described in this or any educational activity. A qualified healthcare professional should be consulted before using any therapeutic product discussed herein. The following presentation is part of a certified educational activity provided by Medscape Education and supported by an independent educational grant from Ardellix.
Welcome to this Medscape educational event, From Symptoms to Success, Real-World Cases and Patient-Centered IBS Care. My name is Brian Lacy. I'm a professor of medicine at the Mayo Clinic in Jacksonville, Florida, and I'm absolutely delighted to be speaking with you today on patient-centered care for patients with IBS and constipation. In this program, we'll discuss an overview of IBS with constipation and its impact on patients. We're going to discuss some cost-effective and efficient ways to accurately diagnose IBS with constipation. We'll discuss best practices for treatment, including advancing therapy from OTC, over-the-counter treatments, which is a common problem we all encounter. We'll discuss the use of prescription IBS medications, and we'll discuss patient-centered IBS with constipation care, and that's so critically important. So to set the stage, let's discuss what IBS really is. And IBS is a disorder of gut-brain interaction. We now call this a DGBI, disorder of gut-brain interaction. And the way I explain it to my patients is that we have this bi-directional highway between the brain and the gut of millions and millions of nerves. And remind your patients that they have more nerves in the GI tract than the spinal cord. The GI tract is a sensory organ. And when there's disruption in this brain-gut axis, for example, there's inflammation in the gut, there's a change in the gut microbiome, that can lead to changes in gut sensation, gut motility, and those changes can then affect the brain. Conversely, we can think about how external influences, poor sleep, stress, psychological distress, such as depression and anxiety, can affect the brain, which then can affect the GI tract. And that's important to really educate your patients about so they understand why you're going to be discussing various therapies to target this disrupted brain-gut axis. So let's use a recent case to illustrate some of these teaching points. And this is a 42-year-old woman. She's married. She has 3 children. Her parents are getting older. She has somewhat of a stressful sales job. She has a 10-year history of constipation symptoms, and she's noted in the last few months that symptoms seem to be worsening. She's having more days with abdominal pain, more problems with gas and bloating, more constipation symptoms of incomplete evacuation with some straining at stool. And she's noted that these symptoms have really affected both her home life, situation with her husband and family, but also her work life. And she actually gave up a promotion because she found that was going to be too stressful with travel and how it would affect her symptoms. So the question I want you to think about is, what other information might you require to make an accurate diagnosis and initiate a treatment plan for this patient? All right, let's think about symptom presentation in patients with IBS and constipation in the United States. And this is a great bar graph showing that when we think about IBS, irritable bowel syndrome, it really is a syndrome. It's a constellation of symptoms. And we recognize that patients should have abdominal pain. You may ask, why isn't this 100%? And that's because some people don't describe their abdominal pain as pain, but rather as discomfort. This exists on a spectrum. And of course, patients have symptoms of constipation. You'll notice too that many patients have symptoms of bloating. And this is a common symptom presentation in patients with disorders of gut brain interaction, whether IBS or chronic constipation or functional dyspepsia. And as a syndrome, you'll notice too that many patients have other foregut symptoms. So don't be surprised if somebody comes in with dyspeptic symptoms and reflux along with their IBS and constipation symptoms. So how can you tease out this disorder of IBS, in this case, IBS with constipation, from other disorders? Well, let's think about the timing and the chronicity. Remember that IBS is defined as a chronic disorder. Symptoms should have started at least 6 months ago. So when somebody just starts with constipation symptoms, that's not IBS. It may be occasional constipation or medication induced. The sine qua non, really the cornerstone of the diagnosis of IBS, is the presence of abdominal pain or discomfort. So make sure you ask about that. Don't be overwhelmed if patients come in and they have a multitude of symptoms, dyspeptic symptoms, globus, heartburn, non-cardiac chest pain, bloating. That actually should reassure you that this whole constellation of symptoms likely is a disorder of a gut-brain interaction, and instead don't think that they have 13 or 14 separate individual diagnoses. We're going to discuss alarm symptoms in a second, and then factor in the pretest probability. We're all worried about maybe missing a case of inflammatory bowel disease in somebody with IBS and diarrhea symptoms, but that's uncommon. It's 1 in 1,000, 1 in 2,000 people. IBS is common, 1 in 10 patients. We're going to talk about a good aspects from the physical examination, what to look for, and we're going to think about what diagnostic tests might I need, because a key teaching point is not all patients need testing, and they certainly don't need a battery of tests. So I mentioned those alarm features. So certainly, if somebody has a family history of colorectal cancer or inflammatory bowel disease, I'm going to be digging in a little bit more carefully. I'm a little bit more concerned that patient who's 65 and has new symptoms of IBS constipation. Is it possible? Yes, but is it likely? No, compared to somebody in their 20s and 30s. I ask about unintentional weight loss. I ask about bleeding and blood in the stool. I ask about nocturnal symptoms or symptoms that are rapidly progressive in nature. Those are the things that make me a little bit more concerned, and I will likely be doing a little bit more digging in terms of diagnostic tests. Now, a great clinical pearl is to think about conditions that can mimic or coexist, and that's a key teaching point too with IBS. So in the United States, we recognize that about 35% of adults are lactose intolerant, and that can cause bloating and change in bowel habits, usually diarrhea. In some populations, it's as high as 85 to 95% in some Asians and in Blacks. We can think about small intestinal bacterial overgrowth, which may be a culprit in the generation of IBS, but can also coexist. Celiac disease, we discussed pretest probability. In the United States, it's 1 in 200 people, 0.5%. However, non-celiac gluten sensitivity, where people are sensitive to wheat products, and it's generally the fructan in the wheat, that's 30%. So 3 out of 10 adults. So this slide is nice to illustrate and to just focus on for a second. Think about these conditions. Think about this as your differential diagnosis as you're approaching these patients. So as you're reviewing things with the patient and interviewing them in the office, it's nice to kind of think about their perspective. And this really helps with a very well strategized patient visit that's going to be successful. So you need to understand, what are they thinking about for their illness? And I always ask, what do you think is causing your symptoms? What are you worried about? What do your friends and family members think about your symptoms? You may want to ask about coexisting psychological distress, especially anxiety, because you can imagine that if somebody has GI symptoms that don't seem to be improving with reasonable therapy, that could make them anxious. Their anxiety, that disorder of gut brain interaction, will further worsen GI symptoms. So it's important to get that under control. And as we learned with this patient, These disorders, IBS with constipation, can significantly affect quality of life, and that will help with your treatment decisions. Somebody with very mild symptoms may only need dietary intervention. Somebody with more severe symptoms affecting quality of life may need a multi-component strategy. So we've already alluded to the diagnosis. Remember that IBS is a chronic disorder, so we like to think about symptoms that started at least 6 months ago, that have been active in the last 3 months. And basically, it's the presence of abdominal pain or discomfort with altered bowel habits. And you don't need to have abdominal pain or discomfort every day, just 1 day per week on the average. And that abdominal pain or discomfort is related to having a bowel movement. It may be related to change in stool frequency or stool form. And so for many of these patients, they'll talk about hard stool, hard to evacuate stool, and that after having a bowel movement, there's some temporary improvement in symptoms. So how do you make that positive diagnosis? Using the Rome 4 criteria, and these will be changed slightly this coming May with the publication of the Rome 5 criteria. What I like to discuss is what I call the 4 Cs that you may wish to check if not recently checked: a CBC, a CRP, and in those with uh, diarrhea symptoms, celiac serologies, and a fecal calprotectin. But it's important to understand that not all patients require testing. A younger patient without any warning signs at all, who had a recent CBC, they probably don't need anything at all, and you can proceed with just treating the predominant symptom. It's important to highlight too, especially in some countries where resources are very limited, you don't need to do a colonoscopy in all these patients. And for those of you listening in today, think about some of your younger patients who underwent colonoscopy, and it's very unlikely, and this is data-driven information, it's very unlikely that you will find anything that's causing their symptoms. And certainly for patients with chronic symptoms, the yield of stool studies is vanishingly small, and we would not recommend that. Unfortunately, still in this time and age, we don't have a great single biomarker, but I might suggest that you taking a great history, doing a careful exam, and doing some of this limited testing, that's still the best biomarker when combined with the Rome criteria. And a key teaching point too is at that first visit, make an accurate diagnosis, tell the patient what they have, and get treatment started. You don't need to keep waiting if you decide to do testing to initiate therapy. Get therapy started early. All right, so let's reflect on this patient again. She's had lower abdominal pain or discomfort at least a day per week. She has some bloating. She has symptoms of constipation. She's on a normal fiber diet, and that's a key teaching point because adding more fiber probably won't help. Her weight's been stable. There are no warning signs, and she's used some over-the-counter medications. Testing, including a CBC and a CRP, was normal. A thyroid test was normal. Occasionally, significant hypothyroidism can drive these constipation symptoms. Because of the bloating, she underwent a breath test, and there was no evidence of bacterial overgrowth or excess methane production called IMO, intestinal methanogen overgrowth. Now, let's look at the middle column and think about prior medication trials. She's tried stool softeners. She's tried polyethylene glycol, a variety of probiotics, aloe vera juice, and fiber supplements, but none of these have really been effective. And this is something that I'm sure all of us face all the time. So keeping in mind that she's had really no success with these over-the-counter agents, the question is, what should we do next to improve her symptoms? Let's look at the options. All right, and before we discuss the treatment options, let's think about how to make that visit successful. So set realistic goals, and that's so critical. Set expectations. We cannot cure IBS in this day and age, but similarly, we don't cure thyroid disease. We don't cure high blood pressure, right? We treat it. And so what your message should be that day is, I'm really going to do my best, Mrs. Jones. I'm going to do my best to improve your symptoms. We can't cure this, but there are lots of therapeutic options out there. Let's do our best together. And then making sure that you really work with the patient to develop a strategy, a treatment plan that they will be involved with. It's easy to give a prescription, but if they're not going to get it filled, if they're not going to take it appropriately, that's of no value to either of you. So make sure you develop a plan together that they will follow. and make sure you get their questions answered. What do you think about this? Will you be able to follow this? What else do you want to have answered? What therapies have you heard about, and what might be most important for you to address? And don't forget, as you do some of this, use some of the patient's words. And so oftentimes I'll use a great strategy of saying, Mrs. Jones, what I heard you say was pain is really bothersome. It's affecting your quality of life. The things you've tried have not helped yet. Let's discuss other treatment options and use their words. This slide, I'm going to just make a few highlights because there was a great Medscape program a few weeks ago by Dr. William Che at the University of Michigan, focusing just on treatment recommendations. That's archived and should be available online in a few weeks. The numbers illustrate kind of where it is in the treatment strategy. So certainly using AGA guidelines, American Gastroenterology Association, lifestyle interventions, exercise, and dietary modifications would come first. Medications listed as number 2 might come second. And then this clock here shows that for things that may not, for if you still have persistent symptoms and you've failed those other therapies, you may want to consider these other treatment options. Shown in green are the ACG, American College of Gastroenterology recommendations, and you can see that frequently there's great overlap between AGA and ACG. All right. So what are some of these basic approaches? Let's encourage physical activity. We know that physical activity can stimulate the gut, and for somebody with IBS and constipation, it can be very useful. It's also good for your brain, and we've talked about this brain-gut axis. Obviously, if patients are on medications that slow GI transit, high-dose calcium channel blockers, opioids, of course, and think about GLP-1 agonists, because remember, GLP-1 agonists can slow the GI tract. This patient was on a normal fiber diet, but we recognize that at least 50% of Americans are fiber deficient, so double check that. And then again, personalize your treatment plan. And when we discuss what she's used before, make sure that she used them appropriately and for reasonable periods of time. ACG, American College of Gastroenterology, and AGA does recommend fiber because fiber, especially for IBS constipation, it's simple, it's easy, it's cheap, it's safe, but it may not improve abdominal pain. And don't forget, it can worsen bloating in many patients. The ACG actually recommended against polyethylene glycol for the treatment of IBS with constipation. The reason being is we focused in that guideline on improving overall global symptoms of IBS. And remember, the cornerstone of the symptom presentation, the cornerstone of diagnosis, is the presence of abdominal pain, and polyethylene glycol does not help with abdominal pain. Stimulant laxatives, I do not recommend for chronic GI symptoms such as IBS or constipation, but they can help occasional constipation. Think about that patient who gets constipated while traveling. In addition to thinking about things that work, it's also good to think again about things with limited utility, and this slide highlights that. For example, we've already talked about polyethylene glycol, but prebiotics have very low value. Probiotics, the data is very weak at best. Looking at over 83 studies involving nearly 10,000 patients, probiotics were barely better than placebo at improving abdominal pain. A question came in through the chat asking about the use of smooth muscle antispasmodics. I do not recommend them for chronic use. They may help abdominal pain due to spasms when used intermittently, and certainly may help postprandial distress and postprandial pain in some patients, but I recommend against routine use, and chronic use may actually worsen constipation symptoms. All right, so key teaching points, again, if patients are using over-the-counter therapies that may be reasonable for mild IBS constipation symptoms, but make sure that all therapies are for a reasonable period of time, 3 to 4 weeks, and they've used them at a maximum dose. As you interview these patients, let's not reinvent the wheel. That's a big mistake that providers in all situations make. If somebody's tried a high fiber diet for a while, if they've tried exercise, if they've tried over-the-counter agents and they haven't worked, don't repeat that. Move on to something else. So what are those options that we have when patients fail over-the-counter therapies? And this slide illustrates the 4 FDA-approved medications now available. Lubiprostone, approved 18 years ago, linaclotide, a GCC agonist, lecanatide, another GCC agonist, and tenapanor, which is kind of the new kid on the block. It inhibits the sodium hydrogen exchange isoform 3. It has a different mechanism of action, and it's labeled as a retainagogue. This slide illustrates how linaclotide and plecanatide act on the GCC receptor to stimulate fluid secretion, increasing peristalsis and helping visceral pain. Down here, lubiprostone acts on the type 2 chloride channel receptor, again increasing fluid secretion in the GI tract, also improving visceral pain. And tenapanor has a different mechanism of action. It blocks uptake of these ions and therefore keeps fluid in the GI tract, stimulating peristalsis, improving abdominal pain. What's the data to support their use? This slide illustrates some of the pivotal studies leading to FDA approval for lubiprostone, the chloride channel activator on the left, linaclotide and plecanatide in the middle and right columns, the GCC agonists, and consistently looking at global IBS symptoms of abdominal pain and altered bowel habits, lubiprostone, shown in blue, linaclotide, shown in pink red, and plecanatide, shown in blue, were significantly better than placebo. Similarly, tenapanor, shown on this slide, in 2 studies involving nearly 1,200 patients, tenapanor at 50 milligrams twice daily was significantly better than placebo at improving these global IBS symptoms of abdominal pain, discomfort, and altered bowel habits. In terms of side effects, these are generally well treated. We do not need to monitor any of them with EKGs or electrolytes or any type of blood work. The most common side effect in all of these is diarrhea. Remember, these are stimulating the GI tract, so that's not uncommon. Just let your patients know up front that when they start this medication, whether you choose linaclotide or lubiprostone or plecanatide or tenapanor, they may get some mild diarrhea that's usually temporary and self-limited. So let's go back to this patient. We started her on linaclotide at 290 micrograms once daily. She noted a significant improvement in constipation symptoms within the first week, and that's very typical. Slowly over time, she noted an improvement in abdominal pain and discomfort, and she was really very satisfied. Quality of life improved. And the nice teaching point here is one medication was used instead of multiple different medications to address the multiple symptoms of IBS. Let's shift gears a little bit and briefly talk about this 31-year-old man. He's single, he's in between jobs. He had been diagnosed with IBS and constipation 7 years ago, but he's noticed a significant worsening of symptoms with more abdominal pain, a lot more straining, trying to pass hard, rocky stool that's very difficult. And this is really worsening his quality of life as well. Blood work has been normal, a blood count, a CRP, a TSH. Because of some bloating, once again, he was checked for bacterial overgrowth or excess methane, IMO, intestinal methanogen overgrowth, and this was normal. He was young without warning signs, but because of persistent symptoms, he underwent a colonoscopy and even a CT scan. Not surprisingly, young person, no family history, no warning signs. These were normal. He's tried a variety of over-the-counter agents, Docusate, polyethylene glycol, probiotics, bisacodyl tablets, and you can see, and he even used 2 different prescription medications, but he's really been struggling with his symptoms. So what's the approach? One is when you hear this story of somebody struggling with persistent constipation symptoms, don't forget about pelvic floor dysfunction. What I tell my patients is going to the bathroom to evacuate stool should be really easy, but it's really complicated and a lot of things have to happen. And pelvic floor dysfunction is basically discoordination between the muscles in the pelvic floor. And many patients feel like they are pushing to evacuate, but instead they are clamping down. And this can be easily diagnosed with a good, careful rectal examination. By the way, always make sure you have a chaperone present for both men and women. But it can also be diagnosed with anorectal manometry and a balloon expulsion test. And this is critical because these patients respond to physical therapy, but not medications. So you want to identify that. And we know that this is present in at least 30 to 40% of patients with IBS. One question that came up through the chat today as I've been looking at the questions is what about the use of combination therapy? So we call that augmentation therapy. And we do that for a variety of other disorders. Think about your patient with high blood pressure, where maybe you combine 2 different agents. And we do that all the time in these disorders of gut-brain interaction. And you may do that because maybe one medication at a higher dose had a side effect, so you drop the medication. And so then at a lower dose, you don't get the side effects, but maybe the benefits aren't completely transparent. So you need to layer on or add on another medication. So as an example, maybe you're using an intestinal secretagogue, but then you add on a tricyclic agent to help with visceral pain. Or maybe you're talking about using a medication and diet. Or maybe for this patient, you're talking about using physical therapy and a medication. The concept of augmentation therapy is really nicely demonstrated in this patient. So to begin, we educated this patient about his condition, about how common IBS is, and that provided some reassurance. We also reassured him that IBS with constipation never turns anything bad or dangerous and does not shorten lifespan. As we were developing a treatment plan together, and that's important, I made sure that all of his questions were answered. Anorectal manometry and a balloon expulsion test showed clear evidence of pelvic floor dyssynergia. He thought he was pushing to evacuate stool, but instead he was clamping down instead and holding back stool. And that was a critical pathway forward because that means we initiated physical therapy because pelvic floor dysfunction does not improve with medications, but it does improve with physical therapy. In addition, for his IBS with constipation symptoms that had failed over the counter therapies and two other prescription medications, we started something with a new mechanism of action, in this case, tenapanor, that's sodium hydrogen exchanger isoform 3 at 50 milligrams once daily. The FDA suggests 50 milligrams twice daily, but for many patients, I start once daily to minimize any chance of a side effect, and then I can increase the dose twice daily if necessary. He reported back that his constipation symptoms had significantly improved at 6 weeks with the combination therapy of tenapanor and pelvic floor dysfunction, but he was still having some lower abdominal discomfort that was bothersome to him. And that's not uncommon. Many patients with medications and physical therapy still have some component of visceral pain. So for this patient, we started a low dose neuromodulator, in this case, disipramine, which is a secondary amine tricyclic agent, which is much less likely to cause side effects compared to a tertiary amine. So we started low dose disipramine to help with visceral pain. It also helped with a little bit of sleep disorder. And as we mentioned before, poor sleep changes sensory thresholds and worsens IBS constipation symptoms. At 4 months, he reported back that he felt significantly better compared to when I saw him in the office for the first time, with a significant 75% improvement in symptoms, which is very reassuring to him. So, with that in mind, let's summarize again what's really good patient centered care in IBS to make a successful visit. And the first thing is they want you to listen. Don't be the average healthcare provider who interrupts after 18 or 19 seconds. Let patients get their story out. That's actually therapeutic. Educate your patients about their condition. Remind them that IBS is common, 1 in 10 adult Americans. And to some degree, that also provides reassurance that they are not alone out there and reassure them that, again, this never turns anything bad or dangerous and does not shorten lifespan. Make that positive diagnosis. Don't use wishy washy language such as, Mrs. Jones, you might possibly have a condition that could be IBS. Instead, say, Mrs. Jones, in my experience, you have IBS with constipation. Let's discuss treatment options for this common problem. And of course, working with the patient, working together hand in hand, you're going to develop a treatment plan together that should lead to symptom improvement. Another question that came in from the audience, again, wanted to focus on the use of antispasmodics. Let me just cover that again, that we don't routinely use this for chronic use. It can be used for intermittent use, but not for chronic use because many patients become resistant to therapy, but it can also worsen constipation symptoms. Another question that came up from the audience is, how do you choose one agent, one of these 4 FDA-approved agents over the other? All of them are very good. We saw that they are better than placebo. We know that they are effective. Sometimes the choice is what the patient has tried before, again, asking that patient history. And then the other point is sometimes it's driven by insurance. I'm going to stop there. Thank you so much for spending time with us today. We hope you learned some new information about IBS with constipation. And also, Recently, I mentioned a Medscape lecture by Dr. William Che at the University of Michigan, focusing on the treatment of IBS with constipation, and a great lecture by Kim Carter, a physician's assistant and expert in IBS. Those have been archived and should be available online for your review. Thank you again for joining us today, and we welcome you back for future Medscape educational events. From Jacksonville, Florida, I'm Brian Lacy, professor of medicine at the Mayo Clinic in Jacksonville. Best wishes to everybody for a wonderful spring.